Welcome to the Hospital Medicine Unplugged podcast.
Great to be here.
Today, we are undertaking a deep dive into, well, arguably one of the highest stakes, most time-sensitive diagnoses a hospitalist will ever face. Acute bacterial meningitis.
Absolutely. It's a true neurological emergency.
Our mission really is to move beyond just the textbook knowledge.
Yeah.
We want to synthesize the latest evidence, especially looking at the Infectious Diseases Society of America or IDSA guidelines,
Right.
and build that into an immediate, actionable protocol for hospitalists like you listening.
And the stakes just couldn't be higher. I mean, bacterial meningitis, it's still a devastating global health emergency. When you look at the data, the need for a standardized, really rapid protocol just screams out at you.
Yeah.
Mortality rates, they're often cited as reaching, 54% in resource-limited settings. That's staggering.
It really is.
But even here, in our hospitals, the long-term morbidity, just unacceptable.
Yeah.
Exactly. We know neurological sequelae, things like hearing loss, cognitive dysfunction, focal deficits, they impact up to 24% of survivors.
A quarter of them.
Yeah. For us, time is brain. Every single choice made in that first hour, that first 60 minutes, it critically determines the patient's long-term outcome. It really does.
That sets the stage perfectly. So before we even talk about the clock ticking, let's understand the landscape of the infection itself.
Okay.
We need to start by knowing our enemy, right? Clearly defining the critical epidemiology, the etiology, because this informs every single decision we make about empiric coverage later on.
Right. You need to know what you're likely treating. So if we focus on community-acquired bacterial meningitis, specifically in adults, the pathogen predominance is just. It's striking.
Okay.
Strep pneumonia, pneumococcus, that's the overwhelming culprit.
Really dominant.
Hugely dominant. And it counts for about 72% of all cases. 72%.
Wow.
So that's the organism we're primarily targeting with the bulk of our empiric strategy.
Okay, so 72% really dictates that initial thought process, high-dose vancomycin, cephalosporins. We'll get into the specifics later.
Exactly.
But strep pneumonia isn't the only player, even if it's the biggest. What comes next on that common list?
Well, the second most common is Listeria, or meningococcus. Meningococcus. That accounts for around 11% of cases.
Still significant.
Definitely. And while it's less frequent than pneumococcus, meningococcus carries this really high virulence. It's often associated with rapid deterioration.
Yeah, the scary presentations.
Exactly, often involving widespread vascular collapse, DIC, disseminated intravascular coagulation. It makes it an immediate public health concern, too, not just a medical crisis for that one patient.
Right, because of the transmission potential.
Precisely.
And then we have to move to that crucial exception, the one based on patient demographics, the coverage for Listeria monocytogenes.
Ah, yes. Listeria.
This is one of those mandatory additions that hospitalists just cannot afford to miss.
You absolutely cannot miss it. Listeria monocytogenes, it's this opportunistic pathogen, and it demands dedicated coverage. Specifically, ampicillin.
Ampicillin, right.
In specific, vulnerable host groups.
Yeah.
You absolutely must cover for it in neonates, the elderly, usually we say age greater than 50, any immunocompromised patient, pregnant patients, or those with underlying alcoholism or cirrhosis.
So quite a broad list of at-risk.
It is.
Huh.
And missing that coverage, missing the ampicillin, is a major driver of preventable bad outcomes in these specific groups.
And it's important to remember, isn't it, that Listeria often presents a bit differently, maybe slower, less fulminant meningitis sometimes.
It's often true, yeah.
Yeah.
But the problem is the host is often less able to mount an effective defense.
Right.
Which is why the mortality is still so high when it's missed, even if the onset isn't quite as explosive as, say, meningococcus.
Okay. And just briefly touching on pediatrics, because it highlights the importance of age for neonates. The bugs are completely different, right?
Totally different world. In neonates, you're primarily looking for E. coli and strep aglaxiae, group B strep.
Right.
So it just underscores how critical that history and age stratification is before you even think about starting therapy.
Absolutely. Now, another crucial distinction, the clinical setting itself, it completely reframes the list of likely culprits.
Yes. We have to be really clear distinguishing community-acquired cases from healthcare-associated or nosocomial meningitis.
And this distinction is so vital because those nosocomial bugs, they're often nastier, more drug-resistant.
Exactly.
And they need vastly different empiric antibiotics. So we're talking about meningitis that develops after, say, a recent neurosurgery.
Neurosurgical procedures, yep. Head trauma is another big one. Or the placement of any CNS device.
Like shunts.
Shunts, external ventricular drains, EVDs, things like that.
Okay. So in that nosocomial setting, what are the common culprits we're worried about?
Well, here you're thinking more about skin flora, ironically. Specifically, coagulase negative staph.
Staph epi.
Like staph epidermidis, exactly. Right. And of course, the more virulent staph or EDS.
It makes sense post-procedure.
Right. And critically, we also see a high prevalence of really problematic aerobic gram-negative bacilli.
Uh-oh. Like which ones?
Think Pseudomonas aeruginosa. It just loves to colonize wet environments like surgical sites or those shunts we mentioned.
Okay.
Along with various Enterobacter species. And this immediately tells you, as the hospitalist, that your standard third-gen cephalosporin, like ceftriaxone, it's probably going to sail.
Right, not going to cut it.
Not going to cut it. You have to switch gears immediately to an anti-pseudomonal beta-lactam.
That's a fundamental clinical pivot point right there. Okay, before we move into the whole diagnostic workflow, maybe we should just briefly touch on the other things that can cause meningitis-like symptoms, the atypical presentations.
Yeah, good point. Just as a sort of warning sign for listeners.
We're focusing hard on bacterial because it's the emergency, the thing that kills quickly. But not all inflammation in the meninges is bacterial.
Correct. You have viral meningitis, of course, often caused by enteroviruses, sometimes HSV2 or varicella zoster virus.
How does that usually present?
Typically, it's more subacute, usually a milder course, self-limiting, though the headache can be absolutely brutal.
Right.
The real danger zone, though, is often in the immunocompromised patient. That's where chronic or fungal causes become really critical considerations.
Okay, so now we're talking about things like
pathogens like Cryptococcus neoformans. You think about that, especially in advanced HIV/AIDS, or maybe patients on biologics.
Okay.
And Mycobacterium tuberculosis. TB meningitis.
And these tend to present differently, too.
Very differently often. They can have this really subtle subacute onset over days, even weeks. They often lack that explosive, dramatic start you see with pneumococcus or meningococcus.
Which sounds like it could really complicate the initial diagnosis.
Severely. So the hospitalist just has to keep a high index of suspicion, even if those classic textbook signs aren't there, particularly in anyone who's immunocompromised.
That complexity, that need for suspicion, leads us right into the time-sensitive diagnostic strategy. This is where the clock truly starts hammering away.
Right.
And I think the first thing we have to do, almost as a public service announcement to our colleagues, is dismantle the over-reliance on the classic triad.
Oh, absolutely.
Right.
We've got to challenge that dogma. The classic triad. Fever, nuchal rigidity, and altered mental status.
Yeah, everyone learns it.
Everyone learns it. It's taught rigorously.
Yeah.
But it is simply absent in a huge number of confirmed bacterial meningitis cases. Yeah. Huge number.
So relying on it means you'll miss cases.
You will cause catastrophic delays if you wait for all three.
Okay, so if the triad is unreliable, what's a better clinical guide? What should we be looking for?
Well, the more reliable clinical finding, based on major studies, is the presence of at least 2 of the following 4 symptoms: fever, nuchal rigidity, altered mental status, or headache.
Okay, 2 out of 4 is much more sensitive.
Much more. That combination is present in up to 95% of patients with bacterial meningitis.
95%. That's a number to remember.
It is. And furthermore, we just need to accept that those classic physical exam signs like Koenig's and Brzezinski's, they're notoriously unreliable. They might help confirm it if they're positive, sure. But their absence should never be used to rule out meningitis. Never.
Okay, good point. Low sensitivity. Now, this brings us to probably the biggest logistical hurdle, the thing that often blows past that critical 1-hour window.
Ah, yes. The imaging decision.
The neuroimaging decision. CT brain before the lumbar puncture, the LP. What's the definitive guidance here?
The IDSA stance is absolute on this, and every hospitalist needs to internalize it.
Yeah.
Empiric antibiotics must not be delayed for neuroimaging or for the LP.
Not delayed, full stop.
Full stop. Antibiotics go in immediately, period. If the LP is needed, the only question is whether you need a CT scan before you do the LP.
And when do you need that CT first?
The CT brain beforehand is only indicated for specific high-risk features that suggest maybe there's a mass lesion or an imminent risk of brain herniation if you do the LP.
Okay, let's list those critical features again, because this is like a checklist every hospitalist should have burned into their memory.
Agreed. The features are significantly altered mental status or a reduced level of consciousness. Think Glasgow Coma Scale score less than 10, maybe.
Right.
The presence of focal neurological deficits on exam,
Right.
the finding of papilledema when you look in their eyes with a fundoscope,
Got it.
the presence of any underlying immunocompromising conditions. That's a big one.
Why immunocompromise specifically?
Because those patients are at higher risk for other CNS processes like toxoplasmosis or PML that can mimic meningitis but represent a mass lesion.
Ah, okay. Makes sense. Any others?
And finally, a history of prior CNS disease. So if they have a known mass lesion or a history of stroke or hydrocephalus.
Okay. So if none of those specific high-risk features are present,
Then you draw the blood cultures, you give the antibiotics and the steroids, we'll talk about steroids, and you proceed immediately to the lumbar puncture. No delay for CT.
okay. Now, let me throw in a real-world friction point here. We all agree, give the antibiotics immediately.
Yes.
But what happens when the patient clearly needs an LP? Maybe they have altered mental status, but no focal deficit, no papilledema, but they're on therapeutic anticoagulation.
The dreaded anticoagulation issue.
Yeah, say their warfarin INR is 3, or they got a dose of Lovenox 3 hours ago in the ED. This often forces a delay of hours waiting for reversal agents or for the drug to clear. How do you manage that immediate, frankly terrifying risk-benefit decision?
That is the ultimate operational constraint, isn't it? It's tough. But if the patient requires that immediate LP, but there's a contraindication because of anticoagulation, the priority must remain the immediate administration of antibiotics and steroids.
Okay, antibiotics still paramount.
Still paramount.
Yeah.
Then the hospitalist has to communicate that high suspicion immediately to neurointervention, maybe hematology, whoever can expedite reversal.
So get the reversal process started fast.
Exactly. While the LP is critically important for diagnosis, a delay of a few hours to safely perform the procedure, provided the antibiotics went in promptly, is far less damaging than delaying those antibiotics for even an hour while you're trying to figure out how to safely get the fluid.
Okay, so the key is never, ever delay that first antibiotic dose. Manage the LP safety issue concurrently, but don't let it stop the treatment.
Precisely. Never delay the antibiotics.
All right, so assuming we get the patient stabilized, they're on antibiotics, maybe the LP gets done safely, the diagnostic focus then shifts entirely to the CSF analysis itself.
Yes, interpreting the spinal fluid.
Let's dig into the key numbers, the classic findings that scream bacterial.
Yeah, we need to know these numbers cold. We're looking for 3 classical indicators in the CSF.
Okay, number 1.
First, a high white blood cell count, and it's dominated by neutrophils. That's neutrophilic pleocytosis. Typically, you're looking at over 1,000 cells per cubic millimeter.
Okay, high white count, mostly neutrophils. Number 2.
Second, elevated protein. Generally, think above 2.2 grams per liter.
Got it. And number 3.
And critically, a low CSF glucose level, usually defined as less than 34 milligrams per deciliter. Or, maybe more reliably, a CSF to serum glucose ratio of less than 0.4.
Less than the 0.4 ratio, okay, those are the classics. But distinguishing bacterial from viral meningitis can sometimes be tricky, right? Especially if maybe the patient got a dose of antibiotics before the LP.
Oh yeah, that partially treated meningitis scenario. It can definitely muddy the waters for the classic parameters, especially the cell count and glucose.
Well, this is where some of the newer biomarkers can really help provide clarity.
Exactly. This is where CSF lactate really shines.
Lactate. Tell us about that.
The utility of CSF lactate, specifically a level greater than, say, 3.5 to 4.2 millimoles per liter. The exact cutoff varies slightly by lab and study, but a high lactate has shown superior diagnostic accuracy compared to just looking at the glucose-protein ratio for differentiating bacterial from viral cases.
Why is it better?
Its key advantage is its stability. Unlike glucose and the cell count, lactate levels seem to be less affected by prior partial antibiotic treatment.
Oh, okay.
So it makes it a really essential, rapid rule-in tool, even if the other numbers are a bit ambiguous because of prior antibiotics.
That's a really key refinement we need to integrate into our practice, using that CSF lactate more routinely.
Definitely.
And we also need to leverage the modern diagnostics. We're moving more and more towards a world where these PCR-based multiplex panels are available.
Yeah, the BioFire Filmary Meningitis Encephalitis panel, for example, their role is becoming profound, especially for antibiotic stewardship.
How so?
Well, they offer rapid identification often within hours of common bacterial pathogens like strep pneumonia, meningococcus H flu, Listeria even, but also key viral pathogens like HSV, VZV, enteroviruses.
So you get an answer much faster than culture.
Much faster. And if that panel comes back positive for a viral pathogen, say enterovirus, and the clinical suspicion for bacteria is otherwise low, meaning the CSF looks pretty clear, the lactate's low, the patient's clinically stable. It gives you the confidence to rapidly de-escalate antibiotics.
Stop the vancomycin, stop the ceftriaxone.
Exactly. Avoid unnecessary drug exposure and resistance pressure.
Okay. But we can't let the fancy new technology make us forget the basics, right? The gold standard is still
Gram stain and culture, correct. Even though their sensitivity is variable, maybe 50 to 90% depending on the study and prior antibiotics.
right. If the patient already got antibiotics, the gram stain sensitivity can plummet.
Absolutely plummets.
Yeah.
Which is exactly why obtaining those 2 to 4 sets of blood cultures concurrently with the LP and definitely before the first antibiotic dose is mandatory.
The blood cultures act as a crucial backup.
A crucial diagnostic safety net. You might get the bug from the blood even if the CSF gram stain and culture are negative, especially after antibiotics.
Okay, that covers the diagnostic approach well. Let's transition now into the treatment phase, and this is governed, as we said, by that rule of urgency.
Yes.
We stated the goal is 1 hour, but maybe we need to reinforce the consequences again. What happens if we delay?
Delays in initiating those empiric intravenous antibiotics are strongly, directly associated with increased mortality, period. That 1 hour window isn't just a suggestion, it's non-negotiable if you want the best outcome.
1 hour, got it.
1 hour, that's the metric. If we miss it, we have likely already caused some irreversible harm.
Okay, so let's detail the standard community-acquired adult regimen first. What's the core?
The core is intravenous vancomycin plus a third-generation cephalosporin. Usually that means ceftriaxone or sometimes cefotaxime.
Okay, Vantec and ceftriaxone. Let's talk about the vancomycin piece for a second. The IDSA guidelines specifically mention needing it in regions with, what, greater than 1% ceftriaxone-resistant strep pneumo?
That's the official threshold, yes.
Yeah.
Greater than 1% penicillin or ceftriaxone-resistant strep pneumonia.
But realistically, in practice...
Realistically, given the severe consequences of missing resistant pneumococcus, almost all hospital protocols, certainly in the U.S., default to using vancomycin up front, period.
Just cover it empirically.
Just cover it empirically while you wait for susceptibility testing. We just can't afford the risk of not covering it initially. The cephalosporin, ceftriaxone, covers the susceptible pneumococcus, it covers meningococcus and many gram-negatives. The VANC covers the resistant pneumococcus and MRSA, though MRSA is rare in community-acquired meningitis.
Okay, and then we have that mandatory addition we keep hammering home, ampicillin, for those high-risk groups.
Yes. Can't forget the ampicillin. Its inclusion is non-negotiable for covering Listeria monocytogenes in those defined at-risk groups we listed. Age over 50, immunocompromised, pregnant, alcoholism, cirrhosis.
So if your patient meets even one of those criteria,
Then the initial empiric regimen must be triple therapy. Vancomycin, ceftriaxone, and ampicillin.
Vantec, ceftriaxone, ampicillin, got it. Now let's contrast that with the healthcare-associated or nosocomial regimen. This is where the antibiotic choice shifts completely, right? Targeting drug resistance and Pseudomonas.
Totally different ballpark. The IDSA recommendation for suspected nosocomial meningitis dictates vancomycin, yes, but paired with an anti-pseudomonal beta-lactam.
Okay, so what are the options there?
We're talking high-dose cefepime or ceftazidime or one of the carbapenems like meropenem.
When would you choose meropenem or acefepime?
Meropenem is often reserved if you have a higher suspicion for extended-spectrum beta-lactamase, ESBL-producing organisms, or if local resistance patterns favor it. But the core principle is guaranteed coverage against those troublesome aerobic gram-negative bacilli, especially Pseudomonas aeruginosa, plus the vancomycin for MRSA and Quegnex staph.
Okay, and what about patients who have a documented severe beta-lactam allergy, like anaphylaxis? What are the alternatives then for that gram-negative coverage?
That gets tricky. For the gram-negative coverage, you might have to transition to something like Astrianam, or potentially a fluoroquinolone like ciprofloxacin.
But penetration can be an issue.
Penetration into the CSF can be a concern, particularly with ciprofloxacin. It's not ideal, often requires infectious disease input. And then you have really specialized scenarios.
Like what?
For instance, if you actually confirm a highly resistant bug like a carbapenem-resistant Acinetobacter, that's a nightmare scenario.
Yeah.
The guidelines actually permit and sometimes require using intraventricular or intrathecal administration of drugs like colistin.
Wow, directly into the CNS.
Directly. Often needs neurosurgery to place the catheter. It's serious stuff.
Okay, now we absolutely have to be specific about the doses because getting adequate drug levels into the CSF requires high, frequent dosing. These aren't your standard pneumonia or UTI doses.
Not even close. You cannot underdose in meningitis. The dosing needs reinforcement. Ceftriaxone is 2 grams IV every 12 hours, not Q24, Q12.
2 grams Q12, got it. Vancomycin.
Vancomycin needs an immediate loading dose, usually 25, 30 milligrams, followed by maintenance dosing aimed to achieve a therapeutic trough level of 15 to 20 micrograms per milliliters.
That 15-20 trough is key, higher than for many other infections.
Much higher, because you need that gradient to drive adequate CNS penetration. Failure to hit that trough significantly increases the risk of treatment failure.
Okay. And ampicillin if you're using it for Listeria.
Ampicillin is 2 grams IV every 4 hours. Q4 hours. That high frequency is critical for maintaining time above the MIC for Listeria.
Okay. Those high doses and frequencies are crucial take-homes. Now, once we start getting diagnostic information back, maybe the cultures start growing something, or those rapid molecular panels result,
Right.
we can hopefully move towards de-escalation, which is obviously important for reducing toxicity and resistance pressure.
Absolutely. Stewardship is key. So empiric therapy can often be safely and rapidly discontinued if, for example, that CSF multiplex PCR comes back positive for a purely viral pathogen and the patient looks good clinically. CSF numbers are reassuring.
That's the immediate payoff of those panels.
Exactly. It enables targeted stewardship. It avoids unnecessarily prolonged exposure to vancomycin or those high-dose third-gen cephalosporins if they're not needed. Or, conversely, if you identify the specific bacteria, you can narrow the coverage appropriately based on sensitivities.
Great. Okay, that perfectly sets us up for the next critical piece, the adjunctive measures. And nothing here is more debated or more important in terms of timing than adjunctive dexamethasone.
Ah, the steroid question.
We really can't stress this enough. The timing is absolutely everything with steroids and meningitis.
Everything. Dexamethasone must be given before or concurrently with the very first antibiotic dose if you suspect bacterial meningitis.
Before or with, not after. Why? What's the rationale?
The physiological rationale is critical to understand. When you give potent antibiotics, they cause rapid bacterial lysis, killing the bacteria in the subarachnoid space.
Right.
This lysis releases massive amounts of bacterial components, cell wall fragments, endotoxins, etc., which triggers a devastating local inflammatory response. A cytokine storm, essentially right there in the CSF.
And that inflammation causes damage.
By that inflammation causes much of the secondary neurological damage, the hearing loss, the edema, the vasculitis.
Okay. And the specific pathogen where we know steroids mitigate this inflammatory damage the best is
Strep pneumonia, pneumococcus. That's where the benefit is overwhelmingly documented.
So the evidence is strongest for pneumococcus.
Yes. Landmark evidence confirms that dexamethasone reduces mortality and reduces severe hearing loss, specifically in proven or highly suspected pneumococcal meningitis.
Okay. What's the dose?
The dose for adults is 0.15 milligrams per kilogram IV every 6 hours, and typically for 4 days.
0.15 milligram IV every 6 hours. And the magnitude of benefit you mentioned.
It's staggering, really.
Okay.
Studies showed dexamethasone reduced unfavorable outcomes, which they defined as death or serious disability, from 52% down to 26% in adults with pneumococcal meningitis.
Wow, it cut the risk of bad outcomes in half.
Pretty much a 50% relative risk reduction in severe harm. It's huge.
That evidence really makes it a cornerstone of initial therapy, doesn't it? But there's a crucial stop rule, a situation where you absolutely must discontinue the dexamethasone.
Yes. This is the critical clinical caveat you cannot miss. If Listeria monocyte ogenes is confirmed, either by gram stain, showing those gram-positive rods, or culture, or maybe PCR,
Okay.
dexamethasone must be discontinued immediately.
Why stop it for Listeria?
The evidence is clear. Continuing dexamethasone provides no benefit in neurolisteriosis, and there's actually data suggesting it might increase mortality in this specific disease.
Okay, so harmful improve in Listeria.
Potentially harmful, yes. So if you start empiric triple therapy, vancomycin, ampicillin, because you're worried about Listeria, you give the first dose of dexamethasone with the antibiotics, but you must be prepared to stop the steroid immediately if Listeria is confirmed on the LP results.
That's a really important practice point. Give it up front, but be ready to pull it if Listeria pops up. Okay, moving beyond the anti-infectives and the steroids. Aggressive management of intracranial pressure, ICP, is also essential, particularly for any patient who presents with significantly altered consciousness, maybe persistent vomiting, or signs of papilledema on exam.
Yeah, ICP management becomes a neurocritical care priority pretty quickly in severe cases. And the hospitalist needs to be collaborating closely with critical care colleagues here.
Are there specific goals we're aiming for?
Yes, we have specific hard targets. We want to keep the ICP less than 20 millimeters of mercury. But maybe even more critically, we need to maintain an adequate cerebral perfusion pressure, or CPP.
And the target for CPP?
We generally target a CPP above 50 millimeters of mercury. Some would argue for above 60, but definitely above 50.
Why is that cerebral perfusion pressure goal so important? What does it represent?
Well, CPP is essentially a mean arterial pressure minus intracranial pressure, MAP-ICP. It represents the pressure gradient that's actually driving blood flow, and therefore oxygen, to the brain tissue. If the ICP rises too high, or the MAP falls too low, the CPP drops, and the brain doesn't get enough blood flow. That leads to secondary ischemic injury on top of the infection.
So maintaining CPP above 50 millimole Hg is crucial to prevent that secondary injury.
Absolutely crucial.
And how do we manage ICP and CPP? What are the interventions?
We usually approach it in tiers. We start with simple things like head-to-bed elevation to 30 degrees. That helps venous outflow from the brain.
Okay, basic positioning. Then what?
Then we rapidly escalate to hyperosmolar therapy if needed. The choice is often between intravenous mannitol or hypertonic saline.
Mannitol versus hypertonic saline. Pros and cons.
Mannitol is an osmotic diuretic. It works quickly to pull fluid out of the brain. But repeated doses can cause dehydration, electrolyte problems, and potentially even rebound intracranial hypertension later on.
Yeah, and hypertonic saline.
Hypertonic saline, often given as 3% continuous infusion, or sometimes boluses of 23.4% through a central line, is increasingly preferred by many. It seems to offer more sustained effect on ICP, and it also helps correct hyponatremia, which can sometimes occur with meningitis due to SIADH.
Okay, and if those aren't enough?
In severe refractory cases where ICP remains dangerously high despite maximal medical therapy, then an external ventricular drain, an EVD placed by neurosurgery, is required.
And the EVD helps how?
It does two things. One, it allows continuous direct monitoring of the ICP, and two, you can actively drain cerebrospinal fluid through it to physically lower the pressure.
Okay, that makes sense. Now, thinking about general supportive care, what about fluid management and seizures? There used to be this old dogma about fluid restriction in meningitis, right?
Oh, yeah, that's definitely changed. Older protocols were very worried about syndrome of inappropriate antidiuretic hormone, SIADH, and cerebral edema, and they advocated for fluid restriction.
But we don't do that anymore.
No, that practice is generally considered harmful now. Many of these patients are septic, potentially in shock, and they need fluid resuscitation, not restriction.
So give fluids.
Yes, avoid restriction unless there's confirmed symptomatic SIADH, in which case restriction might be cautiously considered. Otherwise, maintenance fluids are preferred. Keep them euvolemic.
Okay, good. And what about seizures? Is seizure prophylaxis routine for everyone with meningitis?
No, prophylaxis is not routine for every single patient. That's a common misconception.
So when is it indicated?
It's absolutely indicated for patients who have a prior history of seizures, or if they present with focal neurological deficits, or if there's clear evidence of cortical involvement like inflammation or infarct seen on imaging, or maybe epileptiform activity on an EEG.
Okay, so specific high-risk features warrant prophylaxis.
Exactly. And for any patient who is comatose or has profoundly altered mental status, continuous EEG monitoring is really essential.
Why continuous EEG?
Because studies show that up to a third of these comatose meningitis patients may be having subclinical seizures, seizures only detectable on EEG, which can worsen brain injury and contribute to their encephalopathy. You won't see them just by looking at the patient.
Wow, okay. So EEG is crucial in the unresponsive patient. That brings us to the hospitalist's role in all this. It feels like the hospitalist is really the central coordinator for this incredibly rapid-fire, multidisciplinary protocol.
Absolutely. The hospitalist is the orchestra conductor here. Our core responsibility really is ensuring all those time-sensitive actions get executed flawlessly.
Job number one is getting that empiric therapy started within that critical 1-hour window.
That's job number one. And it means integrating all the steps, drawing the blood cultures, ordering the stat CT if indicated, notifying the team who does the LP. We have to do these things concurrently, in parallel. Not sequentially. Sequential kills time.
Right. This often involves overcoming systemic inertia, bureaucratic delays in the hospital.
It does. We should be thinking about things like pre-approved meningitis power plans in the EMR, or maybe pharmacy protocols that allow nurses to pull and administer those first doses of ceftriaxone and dexamethasone immediately upon physician order, bypassing some standard verification steps.
Streamlining the process.
Exactly. Cutting out every possible minute of delay. Furthermore, we need to ensure early consultation with infectious disease and neurology.
Not just for complex cases.
Not just for complex cases, I'd argue for almost all cases. You need their help with tailoring therapy once cultures come back, managing tricky de-escalation decisions, guiding ICP management if it gets complicated, dealing with refractory seizures, get them involved early.
Okay, beyond getting things started, vigilant monitoring for acute complications is another core duty, right? Especially in those first 24-48 hours when patients are often most unstable.
Absolutely critical. We have to anticipate the worst and watch closely.
What are the big, scary complications we're watching for?
Septic shock is a major one, looking for that profound tachycardia and hypotension. Disseminated intravascular coagulation, DIC, particularly common and devastating in meningococcus disease.
Right, the purpura fulminans.
Exactly. Also watching for evolving hydrocephalus, which might require that EVD, and worsening cerebral edema.
In management of shock.
Aggressive management is paramount. Rapid fluid resuscitation first, followed immediately by vasopressors if needed to maintain that critical mean arterial pressure and cerebral perfusion pressure.
Okay, now let's shift focus a bit towards the longer-term picture. Even with the best possible care, the prognosis for bacterial meningitis can still be guarded. We need to be able to counsel patients and families about the persistent risks.
Yeah, this is a tough part of the job. The risk factors for poor outcomes are pretty consistent across studies. Older age is one.
Okay.
Hypotension on admission is a bad sign. The development of seizures during the illness. And critically, as we've stressed, delayed antibiotic administration. The longer the delay, the worse the prognosis.
And even for those who survive, we mentioned the risk of long-term neurological sequelae is significant.
Very significant. Up to 25%, maybe even higher in some series, of survivors face persistent neurological deficits.
And is there a particular pathogen that carries the highest risk for these long-term problems?
Yes, pneumococcal meningitis, strep pneumonia again. It carries the highest risk for severe neurological sequelae. Specific rates are often cited around 24.7%, almost a quarter of pneumococcal survivors.
Wow. And what kind of problems are we talking about?
Things like permanent focal deficits, weakness, coordination problems. Significant hearing loss is very common after pneumococcal meningitis, and cognitive impairment memory problems, difficulty concentrating.
And this really underscores why that mandatory immediate administration of dexamethasone is so important, specifically for suspected pneumococcus.
Precisely. It's currently our single best weapon against that long-term morbidity, particularly the hearing loss associated with pneumococcal disease.
Okay. One final area we need to cover, infection control and public health measures. Ensuring appropriate precautions and post-exposure prophylaxis are managed promptly. This often falls to the hospitalist initially, right? Before ID might even be fully onboarded.
Absolutely. This is often an immediate responsibility. Mandatory droplet precautions are essential for any suspected case of meningococcus meningitis.
Droplet precautions? Until when?
They need to remain in place until 24 hours after effective antibiotic therapy has been initiated.
Okay, 24 hours after effective therapy.
And crucially, the hospitalist must coordinate or ensure someone coordinates post-exposure prophylaxis or chemoprophylaxis for close contacts of any confirmed meningococcus patient.
Who counts as a close contact?
Usually household members, intimate partners, people sharing utensils or saliva, healthcare workers with direct exposure to respiratory secretions, like during intubation without PPE. Public health departments often help define this.
And what are the agents used for that chemoprophylaxis?
The common options are rifampin, taken orally for a couple of days, ciprofloxacin, often a single oral dose, or a single intramuscular dose of ceftriaxone.
Okay, and this needs to happen fast.
Yes, this is a public health imperative. It needs to be addressed quickly, ideally before the index patient is even discharged, to prevent secondary cases in the community.
Okay, this has been an incredibly necessary, very detailed deep dive into the protocol for managing this incredibly high-stakes diagnosis. Let's try to quickly reiterate those main pillars of management we've dissected, the key take-homes.
Okay, pillar one, radical speed in diagnosis. That means timely LP or indicated neuroimaging, but never letting those diagnostic steps delay therapy.
Pillar two,
immediate high-dose empiric antibiotics within 1 hour. The core is vancomycin plus ceftriaxone. Add ampicillin if Listeria monocytogenes is a concern based on risk factors. Or pivot to vancomycin plus an anti-pseudomonal agent like cefepime or meropenem for nosocomial cases.
pillar three,
Adjunctive dexamethasone for suspected pneumococcal disease. Remember, 0.15 mg kilogram Q6H given precisely with or just before the first antibiotic dose. but stop it immediately if Listeria is confirmed.
And pillar 4.
Aggressive supportive care.
Yeah.
Especially focusing on managing intracranial pressure, maintaining cerebral perfusion, monitoring with EEG in comatose patients, and being vigilant for those severe septic complications.
Excellent summary. Our entire discussion today, it feels like it kept circling back to the single most modifiable risk factor in this disease, time.
Time.
We know that delays in getting those antibiotics started, especially delays beyond 6 hours, are just strongly associated with increased mortality and morbidity. It's perhaps the one thing we have the most direct control over.
Absolutely.
And this really brings us to the final challenge, the final provocative thought we want to leave you, our listeners, with. It's about the structural hurdles in our own systems.
Right. Given that every single minute matters, the question to ask yourself is, what operational changes, what structural changes can you champion in your own hospital's initial triage process?
Yeah, whether that's in the emergency department workflow,
Or through creating those pre-authorized pharmacy protocols we talked about.
or maybe improving the coordination for getting stat LPs done.
Whatever it takes, how can you ensure a definitive, reliable 60-minute door-to-needle time for empiric antibiotics and that first dose of adjunctive steroids for every single patient who walks in with suspected bacterial meningitis?
Because that commitment to fixing the process, that's what ultimately saves brains and lives in this disease.
That's the challenge. It's not just knowing what to do, it's making sure our systems allow us to do it fast enough.
Yeah.
Every time.